this morning. I'm excited to talk to you about the process of opening a new medical practice. I did review the questions and um, the questions that you submitted when you registered for the webinar in advance. I think I'm going to cover most of them today, but if there's something that you'd like to talk more about after the webinar, my contact information is on the last slide. This topic is worthy of much more than an hour, so I'll cover as much as I can. And there will also be time for questions and answers at the end of the presentation. I'm also happy, like Claudine said, to do follow-up webinars on this and similar topics. So if that is of interest to you, please let me know in the survey. Because there's a wide variety of interests represented here this morning, I've opted to cover the more requested topics at a higher level. After a brief level-setting introduction, we'll review a potential timeline, talk about different practice models, and review some benchmarks to monitor as a new practice. Everything we talk about can be taken from the perspectives of both independent providers and hospitals and health systems that are seeking to open a new practice. My bad. So to start, there's two scenarios that we're going to talk about today. The brand new practice starting from the ground up and expanding an established medical group to a new practice location. Much of what we'll talk about today is also applicable if you're considering purchasing an established practice as well. So for independent providers, the thought of opening a new practice is very enticing. They can provide the services and do the procedures that they want to with the equipment that they want to. They have control over staffing and hiring and likely a better work-life balance. Conversely to this, though, the providers also then have significant administrative burden and are responsible for things like hiring, firing, performance evaluations, budgets, etc. For hospitals that are seeking to expand, the referral base is a large factor in determination if they're going to open or purchase a practice, especially if it's a specialty that's not currently affiliated with the hospital. A lot of hospitals and health systems essentially subsidize their physician practices for that referral potential. We're talking about this now because the need for healthcare is increasing and it's not going to slow down anytime soon. This, in large part, is due to the aging population, the Affordable Care Act providing coverage for more consumers, and regulatory pressures. Healthcare in America is one of the most regulated industries in the world, and that adds a significant burden to providers who are going to open their own practices. We all know baby boomers are a large generation that's getting to the age where they require more care. Older people seek medical care at a rate of 3 to 4 times the rate of younger individuals. So as this generation is aging, there's more and more need for healthcare in this country. But physician shortages have been an issue for years, but that population of those physicians is also aging and coming to retirement age as well. And there's a lot to this, to the physician shortage. There's access to education, the cost of education and residencies. All of those things play into why not many as people are seeking to become doctors, but it's generally just not as attractive to be a doctor anymore. They know about the regulatory burdens, the challenges with reimbursement, everything like that. That isn't necessarily something that people want to deal with when they're a doctor. Those who go to school to become doctors generally want to treat patients. On top of all of this, the challenges that urban and suburban areas are facing are multiplied in rural areas, and it's more challenging for them to recruit. Primary care is the largest area of concern right now related to the shortage, though most specialties are at risk. Given all of this, it seems obvious that there's a boom in new practices in the United States, and there's a lot of opportunity, and the evolution of the physician practice is happening right now. We're going to talk about practice models in more detail later in the presentation, but take concierge medicine, for example. This was just a new concept less than 20 years ago, and it's expanded by leaps and bounds and is already being overshadowed by direct care. Quality incentives come in myriad formats now. Many of you will probably remember PQRI, which was daunting at its inception, but now we're post-macro with value-based payment models, and providers are paid based, well, some providers are paid based only on RVUs, which is a huge shift from even back when I started my career, that physicians were still paid just a flat salary. Advances in healthcare also are just mind-boggling when you think about the technology we have now. Procedures that used to keep a patient in the hospital for days are now performed in an outpatient setting and they go home that same night. This shifts the need for surgeons and increases the volume And providers have nearly limitless options when it comes to how they practice medicine in terms of prevention and cures. So all of these are taken into consideration independent of other external factors like inflation, post-COVID volume and revenue decreases, staffing challenges, everything that you can think of right now that all industries are struggling with. In the work we do in revenue cycle, we frequently discuss how physicians and other providers, they didn't go to school to learn how to document and code and bill and understand all of these intricacies of running a practice. But when we're thinking about them opening their own practice, they also didn't go to school to run a business. At least most of them did not. But this isn't something that's for all physicians. So for those of you who do work similar to me and advise physicians on opening new practices, it's important to share all the possibilities for them if they're considering this. If they want to leave a practice because of the administrative burden or the bureaucracy of it or something similar, honestly, the likelihood of them recreating that same environment in their own practice is very high. So they need to go through a lot of considerations when they're determining what they're going to do. And they need to have a clear picture of what they're going to do differently, how they're going to do it, and how it's going to make them money. A lot of people have a lot of great ideas for how to revolutionize healthcare right now, but the funding has to be there for it. There also are a lot of other options to consider, like group practice ownership, that could give them some more of that autonomy and work-life balance that they're looking for. Before we move on, this is a good time to note that I'm intentionally not mentioning telehealth, and it's not because I don't feel like it's relevant or pertinent, but it's because that's a separate webinar all on its own as it relates to implementing telehealth, to opening a telehealth company, to having a telehealth-only practice. The regulatory and reimbursement burdens are immense and incredibly different from what we'll talk about with a brick and mortar practice. And while there have been incredible strides in the permanence of some of the COVID leniencies, there's still a lot of work that needs to be done. So the timeline that I'm going to share, it's general, and it would be adjusted based on your specific needs, the size of the practice, the specialty, the location, all of those things. It's for those with at least a year to research, plan, and prepare, but it's applicable regardless of the phase you're in. Also keep in mind, this is Julie Hardy's preference, although it's much more common for us to be brought in 6 months prior to opening, and of course, we can make that work. This is the high-level timeline. We're going to dig into each of these steps, but this is just the first line to keep in mind of what you're going to be doing as you're opening a new practice. As I go through the next several slides, just keep in mind that these bullets aren't necessarily in sequential order. You may or may not want to do these steps in order. You may not need to do every step that I have as well, depending on whether or not you're purchasing an established practice or if you're expanding a current practice. It's entirely different if you're starting a brand new medical group right off the ground. So when you're going through information gathering, you'll be looking at several elements. You're going to start with a market analysis, and it's going to include looking at your competition and population demographics for the region you're considering. I included a link on the reference slide to the census to get some information, and the Medical Group Management Association also has a really cool tool that can help you look at population growth by zip code. So consider the aging population, for example. This is going to increase the need not only for primary care, but also geriatrics, wound care, ophthalmology, podiatry, all of those services that older adults will seek more often. Most of what we're seeing now in terms of expansion is specialties, specifically those that I just mentioned, but also orthopedics and cardiology have been huge as well. And like I mentioned, you'll also want to consider if a rural location is an option for you. There are some great incentives to expand care to areas where there aren't enough providers. I have physician recruitment on here because we do a lot of work in the private equity space. So there's a solid chance that you already have a physician or all of the providers needed for your practice, depending on your situation. But even this far out, it's important to consider physician recruitment. It's also important to think about your staffing model at this point, because these days, it's very rare for a practice to be staffed solely by physicians unless it's a one-doc shop. And even in that case, they usually have at least a PA or NP helping them as well. But you can also consider certified nurse midwives, advanced practice registered nurses, things like that. And contrary to the physician shortage, there's actually a growth in APPs right now. So that's going to alleviate some of the strain of the physician shortage. But of course, we're waiting for a lot of new regulations to come into play to expand the scope of practice for both physician assistants and nurse practitioners. There's also a lot of compliance and reimbursement considerations in this decision-making process, and this gets really hard because we always think about physicians and nurse practitioners practicing in conjunction with physicians incident to, but in a lot of states and in a lot of different scenarios, non-physicians can have their own practice as well. So when you take that 15% reduction for Medicare, you might not have to take that 15% reduction for other payers. So it's going to be really important to look at the payers in the region that you're considering opening a practice in, because you don't necessarily have to take that 15% hit. You'll also be doing your pro forma or value analysis at this point. I know in the survey, when you registered for this, someone mentioned that they were looking for a pro forma format. So if that is something you're interested in, shoot me a quick email after the presentation and I will send you a couple that we use. But when you're doing your pro forma, take into consideration the anticipated schedule, especially at the beginning. Are you going to be open half days? Are you going to have some weekends, every weekend, more like an urgent care format? Shorter days, certain times of the year, whatever it is. That you also have to work in OR time. So if you are in a specialty where your providers are going to have OR days at the hospital, or if you have an ASD, make sure that you're factoring that in as well, because that's going to shift your anticipated revenue significantly. Assumptions should include average collections per encounter, per procedure, per visit, and by place of service. So if you're a hospital or health system that is expanding to a private practice, you need to take into consideration the fact that your provider-based clinics that are on campus or within whatever designation off campus, those are going to have a lower reimbursement than your independent practices, because the independent practices hold the burden of marketing, overhead, insurance, everything. So they get more reimbursement from payers for that. So if you solely have fee schedules that are based on provider-based clinics, make sure that you're looking into what it's going to look like for independent practices. Also in your pro forma include other revenues such as call pay, medical directorships, research, all of those things. And you're going to use what's determined during the information gathering stage to determine your ramp up period, which is obviously going to be one of the keys to your pro forma. And it's what the banks and lenders are going to be looking at when determining if they're going to back you. And considering if you're going to be offering relocation to providers, this gets expensive. It's not something that you want to factor into your budget at the time of recruitment. You want to know in advance if you're going to be offering relocation, sign-on bonuses, things of that sort. And then determine how much you're going to offer your providers and even your staff for continuing education and memberships. That is a draw for a lot of people, especially non-clinicians. And it's a way, we'll talk about this a little bit more later on too, but it's a way to attract and retain the best staff. And make sure that you're gaining an understanding of value-based contracts with the payers in your area that you'll be contracting with, because again, you're not necessarily going to be relying solely on a fee schedule anymore, depending on what you're doing. So you want to make sure that you know exactly what you're going to be getting reimbursed as closely as you can. And of course, this is going to support all of your funding requests. So the reason that I put contracts and conflict of interest and confidentiality this early on is because you're going to start talking to potential providers very early on, and these documents have to be in place for those conversations. Also in this time frame, if you haven't already, you're going to be choosing at least a general location. A lot of our clients right now are expanding along essentially like the outer edges of the countries. So they're expanding into states like Washington, California, Texas, Florida, Georgia, New York, Pennsylvania. It's a common strategy right now. But yeah, something else to consider is that a lot of the states in the north have snowbirds, and this is going to affect your revenue and volumes as well. So those who are in colder states that have a winter, their volumes likely go down in those winter months when their patients aren't here, but those in the warmer climates, their volume goes up because that's where the snowbirds went. But another thing to keep in mind is that those same patients are likely going to be looking to have surgeries in the fall. So if they need a knee replacement or cataract surgery, they want those things done after the weather is done being nice where they permanently live, but before they head to their warmer climate for the winter. So all of these things come into play with your market analysis. This is also the time where you're going to identify what other support or outside support you need. So you're likely going to need assistance with a realtor, a builder, finance, a marketing company, all kinds of people. You're also going to consider operations such as enrollment, credentialing, contracting. This isn't yet the time to look at supply vendors, but it's when you're going to be looking at those other organizations that you need support from. You're also going to want to start considering funding opportunities as soon as you can. There are, depending on what you're doing, what you need the money for, there's a lot of different options for physicians. There, aside from private equity, there's traditional banks, there's personal capital. Special practice acquisition financing is available through a lot of banks, equipment financing. So there's a lot of options that need to be considered, which is why I say that it needs to be looked into this early in the process. You're also going to be establishing your team at this point if you haven't already. This goes along with contracting with consultants and vendors as needed, but likely at a minimum, you're going to want an attorney and an accountant, but there are other consultants and advisors who will guide you as well. So you might consider it like a business coach. Your insurance agent should also be an active member of your team. And depending on your structure, you might also look for a financial planner and or an investment advisor as well. Once you're within a year of opening, there's a lot of administrative or behind the scenes tasks to be completed. So I have steps such as obtaining malpractice insurance and business licenses pretty early on in the process. Depending on a lot of variables, such as the state you're in, these tasks take more or less time. So it's important to take some of those details into consideration when you're tailoring this timeline to you and your needs. And seek the advice of others who do this all of the time. Like we know in Nevada, a business license takes longer than anywhere else in the country. So you'll want to seek out those who do this on a regular basis, who can give you some of that guidance so that you know how to tailor this timeline to your needs. And of course, the other thing to know, no matter how well prepared you are or how far ahead of schedule you are, there's going to be curveballs. And as the pace picks up and you're within 6 months of opening, you're going to want to have a lot of these things out of the way as early on as they can be, as opposed to waiting to when they can be done. Try to do them as early as you can. And in line with all of the applications, you'll of course need to have your business name established and initiate your incorporation. And one of the reasons that I put malpractice insurance this early is so that you have the ability to shop around. We hear all the time that providers are just going to stick with their current insurance provider, but especially if you're expanding not only to a new state, but even just to a different city, you're likely going to want to look at your other options for med mal insurance. Licensing can take a very long time, not just for the business, but for the providers as well. So it's likely that your doctors are going to have their medical licenses, but your state and region could also have specific needs. A lot of your providers are going to need a DEA license so they can prescribe control medications. You're going to want to look into your CLIA waiver or certificate, depending on what you're going to be doing in your practice. And then you're also going to be looking to select your physical location as early as you can as well. So in the last step, it was to identify a general area. But once you get within a year, you want to know where you're going. And you can build, there's a lot of options. You can build an entirely new practice. You can lease space in a newly opened building, which also gives you some customization options, or you can buy an already established practice. And there's pros and cons to all of these options. We've had clients who prefer to build a new building and lease the extraneous space to other businesses. So it's another investment for them. It's another line of revenue. Not everyone is up for that or wants to do that. Leasing or buying a location that was previously a physician practice can expedite a process when needed. And it sometimes lowers build out costs. But there's different things to keep in mind with that. Different specialties have different requirements in terms of like eye wash stations and other OSHA requirements. So you need to keep that in mind. Just because it used to be a physician practice doesn't mean, one, that it's up to all the current standards, and two, that it's going to meet the needs of your specialty. So depending on your approach and what you're doing, what type of sale it is, you might need to obtain a fair market value appraisal of the practice or other assets. This is the time when you'll do it, and you'll be working with your accountant on that. You're also going to want to set up your banking at this point. I talked about funding on the last slide, but you're going to need access to money at this point. You're going to need to start putting down payments and paying the builders, all of those things. So you'll need at least a checking account and likely a business credit card or something to start a lot of these steps. And you should also, it's not on this slide, but you should also know what services you're providing at this point. There's so many options outside of traditional care that can be provided now, like Botox, specialized physical therapy. A lot of OBGYN practices are doing the pelvic floor physical therapy. So contemplate what you're going to be doing different to attract new patients to your practice. And once you're 6 to 9 months out, I have hospital privilege applications. Of course, that doesn't apply to everyone, but for your providers who are going to need admitting privileges, you're going to need to contact the hospitals that they need privileges with, because they need to be cleared by the medical staff committees and access to all of their systems, things like that. They need time to get that done. And if your providers aren't going to need privileges, if you have a primary care practice and your providers are not going to be rounding in the hospital, you'll want to select a hospitalist group who will round on your patients while they're in the hospital. And your budgets need to be finalized at this point as much as they can. So you should have a more clear picture of the salaries, which should be based on formal surveys. And now that you know what services you're providing, you should have an idea of the costs associated with them. And when I mention equipment, it's not only like lab and ultrasound machines, it's also computers, phones, fax machines, blood pressure monitors, stethoscopes, all of the gauze, Band-Aids, tongue depressors, all of that needs to be considered. I also recommend creating your job descriptions at this point in order to stay ahead of schedule, because this is something that can be done at any point, and this is a point in the process where you should have the downtime to do it. You're going to start hiring certain positions early, like months before you open the practice, which we're going to talk about on this next slide, but this is easily an outsourceable task. You can have a consulting firm or do this, or MGMA. Again, I've mentioned them before. They offer a lot of good job descriptions that you can work from. You can probably Google it and find some, whatever you prefer. But you'll want to have them ready as soon as possible, because once it's time to hire for those positions, you don't want to be held up by creating the job descriptions. Ideally, you'll have at least your medical director contracted at this point, but you're going to start finalizing your clinical staff at this point too. And then depending on your location, there's going to be different payers to contract with. So most practices contract with Medicare. Keep in mind, though, that your Medicare Advantage plans are going to be contracted through the commercial payers. And depending on the specialty and other factors, you'll likely contract with Medicaid and Medicaid HMOs as well, which have their own process to follow. And then outside of those federal insurance companies, you're going to want to do some research as to who the largest payers in the area are where you're opening the practice. So in Michigan, you essentially have to contract with Blue Cross. There's not really a way around it in the state of Michigan, but that's not true in all states. Regardless of where you're at, though, you're likely going to look into Humana, UHC, Aetna, the bigger players like that. But also do a cost-benefit analysis at this point of not contracting with certain payers, depending on your estimates as to what your payer mix is going to be. It can sometimes be advantageous not to participate with insurers, though it increases the administrative burden on your practice, but you could get higher rates by not participating. So if you think you're going to have a small number of patients with certain insurances, think about not contracting with them. Once you've identified the payers with which you'll contract, you're going to start the enrollment and credentialing process as soon as you can. Some payers take upwards of 6 months to finish the process, so keep that in mind. That's why we recommend it at this point. And there's going to be some payers that don't let you start at this point, but you should try with as many as you can. And unless you have someone with a background in enrollment and credentialing, outsource it. It doesn't mean that you have to outsource this function forever, but having someone else managing this process and communication is going to allow you to focus on everything else involved with opening a practice. This is also where you'll determine what you'll outsource. Aside from credentialing, common outsourced functions are billing, care management, collections, things like that. This is also when you're going to need to be evaluating EMRs. This should be done with some type of objective criteria. All too often, we see, especially the smaller physician practices, just go with the cheapest EMR. They think all they need is a place to keep their medical records, which isn't really true anymore with all of the quality reporting requirements and everything else. You need a fully functional EMR that has a lot of options for you that your entire staff can use, that implements or incorporates certain aspects of your business process in an entire practice management system. So come up with some type of objective criteria, but also check references, because there are hundreds of software vendors to choose from, and getting real life experience about how the implementation process went. What does their support look like after implementation? Getting all of those opinions is really going to help you out. Also talk to your consultants that you've worked with, because they've worked with dozens of EMRs and can likely provide really good insight on them. You want to make sure that with your EMR, you have the ability to customize to your practice, but also not customize too much. You don't want your EMR to be one of a kind. You want to make sure that any updates they provide, the training they have, the resources available, they all match what you're doing. You're just able to customize it to the point that you need to. But strong reporting capabilities are also really important. We don't often recommend specialty specific EMRs, but there are a handful of good options. So if you do work with a specific specialty that does have their own EMRs like behavioral health or ophthalmology, give your consultants a call so you can see if they have an opinion on them. And then also, not on this slide, but something to keep in mind is that determining employee benefits is also going to happen around this time. You're going to need to have insurance and workers' comp, and you'll also be wanting to think about the benefits that you'll offer to attract the top talent, not just for your clinicians. So time off, tuition reimbursement, support for certification and credentials, that goes a long way in attracting and retaining your staff. So a few months prior to opening, you're going to want to have your key administrative staff in place. Your practice manager should not be starting the day the practice opens. We still see a lot of children, spouses, and siblings who are functioning as practice managers. We advise against that for a number of reasons, unless they have experience necessary to manage a practice. But whoever is going to manage human resources also needs to start early enough to allow lead time for recruitment and onboarding. Depending on the size of your practice, this could also be your practice manager or practice administrator, but they need to be starting several months before you open in order to have all the staff trained, onboarded, aside from being recruited and hired. You also need your staff who's going to help set up your EMR workflows hired at this time, like not only your practice manager, but a nurse or a medical assistant. The EMR vendor that you go with is likely going to have some good recommendations for how your processes should be set up within your EMR, but your best feedback is going to come from those who work the processes day in and day out. And if you're large enough to have COO and CFO type positions, these should be hired now as well. This is also when you're going to contract with software vendors, and there are myriad software vendors that you're going to need: claims clearinghouses and answering service, chronic care management if you're going to outsource it, aside from your EMR, practice management and billing software, e-prescribing, telemedicine, insurance verification, background checks, credit card processing. All of these will need to be picked several months before you open. And not necessarily software, but you're also going to be selecting your phone and internet provider at this point if you haven't already. You'll also want to have your lockbox set up prior to opening because you should plan to submit claims on day one, and payment can be received in as early as 2 weeks. So you'll want to have it ready as soon as you're open. And I always make sure to point out that you should be joining your local and state medical societies as well, not only for your physicians, but also for your staff, because they offer so many resources related to practice management and are able to offer assistance to new practices. And if you haven't already, which would likely be because some payers don't accept early applications, all payer applications should be submitted at this point. You need to allow time for things to go wrong and for it to get held up for any number of reasons. Don't underestimate the need to build relationships with the payers at this point too, because they're responsible for the financial success of your practice, and having them on your side is going to be key. So since this is your first contact with the payers, make sure that you're taking the time to establish strong relationships with them. Depending on your location and specialty, you may have room to negotiate rates as well. Most practices are going to be paid on a fee schedule and or a quality or value-based care incentive. But if you're providing a service that's going to save the payer money, you likely have some room to negotiate. And also, if you're providing a treatment that has proven ability to lower the cost of care, you'll also have room to negotiate. Marketing for a new practice can sometimes be overlooked, but it's critical to the success of a new practice. It's a unique situation for healthcare because our marketing spans the spectrum of billboards and radio ads to social media. All of it has to be covered because you are marketing to every age range in every geographic area, and you need to cover all of your bases. Patients are drawn to practices for a number of reasons, so all possible mediums should be covered at some point, though not necessarily all at once. If you work with a marketing company, they'll be able to advise on the best strategy based on your size and specialty and location. Marketing for OBGYN is different than primary care and pediatrics, et cetera, et cetera. And you'll see later on how it plays into tracking your metrics. We will talk about that in just a few minutes. It's obviously important to order your equipment ahead of time, especially with in our post-COVID world where supply chains are still struggling in all industries. And I have determining your operating hours as well, because it's important for both marketing and budgeting. If you're going to offer expanded hours, it's a draw for a lot of patients. I personally love that I can get a 6:15 a.m. appointment with my doctor when I need to be fasting, and it's one of the things that keeps me loyal to my practice. But late appointments and weekend appointments are also a draw for people. This is also when you'll decide if there will be half days, weekends, all of those things. And it's going to change your budget depending on the variances you have. So when you're 30 to 90 days from opening, you're getting all your operations in place. You're setting up all of your systems like payroll, accounting, your EMR, etc. You'll also be getting your compliance plan and internal controls in place. You need to be prepared to protect yourself and your practice from a variety of potential risks. This is everything from fraud and abuse to embezzlement. And I can't stress enough the importance of establishing these practices from the beginning, from day one, enough. This is where bad habits are formed, and it's hard to correct bad habits. It's easier to start off with good habits on day one than it is to try to fix bad habits later on. You can do things like purchase a base compliance plan or hire a firm to customize one for your practice, and it's a critical part of your onboarding. It has to be done with every single employee that starts in your practice. This is also where you're going to implement your marketing plan, so you can start getting patients scheduled in your first week. So you're not going to start scheduling patients on day one. You're going to start scheduling them a month or two before you open. And keep in mind that you're also marketing to potential referral sources as well. If you are a new specialty, you're going to be marketing to the hospitals, health systems, and primary care practices in your area as well. And then the biggest step in this phase is to set up your EMR. Like I mentioned, you're going to want to be able to customize your EMR to suit your specialty size and needs. You're going to be building your schedules into your EMR based on what the providers have set. Templates for documentation should be documented and put in the EMR. And these templates should be unique to each service. This would include preventive care, minor procedures, acute problem visits, things like that. And then you're also going to need templates specific to time-based services. All workflows need to be established, including what the MAs and nurses are going to be documenting and where. You need certain forms and assessments, such as the PHQ, to be incorporated within your EMR. Other forms and assessments needed for quality reporting and payer requirements will be built in at this point. So that's things like the HRA and cognitive assessments for Medicare. And now that you've gotten all of the important work of the documentation done, how are your charges going to be entered? What's going to be hard-coded based on orders and documentation, and what will be soft-coded? You'll decide if the providers are going to assign their own codes or if they'll be assigning a coder. Alternatively, you could have the charges entered by the provider but reviewed by a coder before billing. There's a lot of different options. Talk to the other practices in the area, talk to consultants, see what their recommendations are based on your specialty and your provider types. And orders and referrals will need to be set up along with e-prescribing in your EMR. And something that can be overlooked at this point is ordering your references. So things like code books, claim forms, whatever references your physicians require, things like that. And all of your operating procedures should be documented at this time as well. So like I talked about a few minutes ago, you need to have a division of responsibilities. So the staff who collect the cash from patients won't also be responsible for deposits. You need to limit who has access to the accounts and to cash to prevent embezzlement. There's a lot of things to keep in mind when you're managing money in a physician practice. You're also going to need to consider on-call procedures and a policy for the distribution of sample medications, when orders are needed, who shares results with the patients, and how. You're also going to establish processes such as release of information, responding to audits, and also take into consideration financial assistance, discount, and payment plan policies. Also, talk about whether or not you're going to accept healthcare credit cards like Care Credit. They offer a lot of benefits. And it's also a draw for patients, especially if you are providing some of those more costly services. And then this is another function that can be outsourced, or you can purchase out of the box templates from a number of organizations. You can also hire people to document your operational policies and procedures and get advice on best practices. So once you're within a month of opening, you need to get the practice operational. You're going to complete all employee onboarding and training. EMR training takes weeks, and since you have this opportunity, take advantage of allowing your support staff to attend the physician training too, so they can see what goes into all phases of care. This is the perfect opportunity to make sure that your coders and billers can see what your physicians are seeing. It's really hard for them to provide feedback when they're just guessing what the physician's process looks like. You should also have your dashboard and regular reporting set up, and we're going to talk more about metrics in detail in a few minutes. Your website should be live at this point, so you're searchable for potential new patients, and it should share all of your pertinent information. You can consider having your new patient intake forms online so they can be completed prior to the patients presenting for their first appointments. And also have profiles of your providers available as well. It's important for the patients to be able to see what their options are and who will be providing care when they're considering a new practice. You can offer online scheduling, which is likely included in PM software. And you can start scheduling for your first days and weeks as well. Like I mentioned, you should start scheduling for your first patients up to a month in advance, not the day of. That's not going to be the first thing that you want to do the day that you open. And once you're in the final days, make sure that your providers not only know how to document within the EMR and leverage the templates that you created, but that they have a solid understanding of the documentation guidelines as well. You may or may not be surprised to know that there are a large number of providers who aren't aware that the guidelines for office visits changed in 2021. So let me just put in a quick compliance plug here because it's what I do, but your providers cannot follow the old guidelines. It's if a auditor, if a payer, if anyone were to see that, it's taken as they did not stay up to date with the guidelines like they're supposed to, and it was never an option to keep documenting and billing according to the old guidelines. So they need to be up to date as much as they can be, and there were even slight changes again this year. If you'll be using a super bill or encounter form, make sure that it's completed and approved by both the providers and coding and billing staff. And you're going to need hard copies of that made. And same with your consents and privacy notices. Those should all be finalized and have hard copies. You can also consider software like Phreesia that allows patients to complete these forms prior to presenting for care. Patients scheduled in those first few days should arrive early to complete all of these forms, and you'll likely start all of the processes on paper and ultimately transition to online or digital completion later on. It depends on what EMR you have and what software you're utilizing for these. And then keep in mind that you're also going to be troubleshooting things that go wrong in this time. You're going to want to be walking through test patients in your EMR, the full process from appointing to working denials. You'll want to make sure that you understand how every step is going to work in your ENM or EMR and practice management system. And then depending on your patient load, the first day might actually be surprisingly quiet. You'll keep your schedule light the first few days so everyone can acclimate to their processes. Your practice manager and other staff should be observing processes and seeking feedback on what's working well and what isn't. But your EMR vendor should also be available and have someone available to assist you with anything that comes up unexpectedly. And this is also where you're going to identify additional training that's needed. So what I didn't include on this slide are things like continued enrollment and credentialing with the payers that take the longest. It's not a perfect world, unfortunately. So even if you do start your enrollment and credentialing 6 months early, you're still going to have some that aren't complete at the time that you open. So you are still going to be dedicating time to these tasks, even after patients start showing up. And something that's likely to start happening on the first day is patients not showing for their appointments. So make sure that you know how you're going to handle that, what your patient discharge policies are, things like that. And when you do have some downtime, start running your reports. At the very beginning, you're going to have a small amount of data, so you're going to easily be able to identify any issues, miscalculations, et cetera, with that smaller data set. And for marketing purposes, you can also consider a ribbon cutting ceremony and get your mayor or chamber of commerce involved. Make it a big deal and get people excited about the fact that you're open. So now that you're open and seeing more patients, your focus is going to adjust. So review your documentation and coding immediately to combat those bad habits early. Like I mentioned, you want to start establishing the good habits as soon as you can and catch anything that's going wrong quickly. You may still have new staff starting within the first few weeks and months, so make sure that their training and onboarding is completed in full as well. You're going to have turnover right off the bat too. It's easy to get lost in the day-to-day shuffle of operations, so keeping a checklist on each employee is best practice. As soon as you start receiving remits from your payers, start payment validation to make sure that your payers are paying according to the contract. This will likely be a time of working a larger number of rejections and denials as you're working things out with your clearinghouse and payer contracts, your new provider. So there could be NPI issues, any number of things that will need to be worked out in the first 30 days. And I would also encourage you to put the onus on staff to identify opportunities to improve. Implementing daily huddles is an effective modality to solicit this type of feedback so that they can informally and quickly in the moment share feedback on what's working well for them, what's not, and also start focusing on eliminating paper and manual processes. Once the data is available, start making improvements based on trending. And again, just stay in touch with your staff as much as you can, and the providers. Never underestimate the feedback that the providers have. So now that we're done with the timeline, we're going to talk about the potential practice models. So there's 3 that we're going to talk about this morning. There's traditional, direct, and concierge. So this is the model that most of us are familiar with, both as patients and those who work in healthcare, the traditional practice model. Unfortunately, what we find is that the payers, whether they're government or commercial, dictate a lot of the care that can be provided in practices. Providers are limited in terms of the provision of services and payments, and this comes in the form of authorizations needed, determination of services that may or may not be billed on the same date, things like that. It's incredibly frustrating, especially in the line of work that we do, when we hear from our providers that the payers aren't following their contracts, and then the appeal process is incredibly onerous, things like that. So those are some of the challenges with the traditional practice model and what's driving the evolution to that direct and concierge model that we'll talk about in a few minutes. Now, don't get me wrong, this has worked historically because so much of the care that we provide right now is focused on curing the sick, not preventing illness. Reimbursement is essentially based on the number of patients seen, which means that there's incentive for a provider to spend as little time as possible in order to see more patients. And this in turn leads a patient to feel just like they're a number, and it leads to dissatisfaction. So the direct practice model is a little bit newer than concierge medicine and is often confused with it. That's what we're going to talk about next. But a defining difference is that direct primary care practices don't accept insurance ever. All services are out of pocket. This model allows the practice to forego dealing with the insurance companies, which lowers the costs and an immeasurable amount of burden on the practice. The membership fee can be collected monthly, quarterly, annually, whatever makes more sense for the practice, and it allows the providers to maintain a smaller patient panel in addition to not having to work with insurance companies. This fee covers most routine medical examinations, treatments, and services, but referrals are made for anything else. And something interesting to keep in mind with this, or to take into consideration, is that there are statistics that show that the average patient panel is between 2,000 and 2,500 patients per provider. But over the last decade or so, with all of the primary care plus and everything else that Medicare has implemented in terms of quality payments, the patient panel has actually dropped from about 2,000 to 2,500 to about more like 1,300 to 1,600. So that's one thing to keep in mind with your physician and provider staffing model. So the concierge model, this has gained traction in the last couple of decades. It used to be considered an option that was only for the rich, but it's a lot more affordable now. And some of these even come looking like executive medicine. So if you are in an area that has large corporations, like in Metro Detroit, it's the auto manufacturers. There's a lot of executive programs where the draw is that the C-suite and other higher level positions can have direct access to physicians at certain hospitals, health systems, clinics for whatever they need. And they have 24/7, 365 access. They can text their doctor whenever they want. They can get whatever services they need. So it's similar to direct patient care in that there's a membership fee and it allows for that smaller patient panel. So the patients are able to get appointments faster. But another draw to it is that they get longer appointments and they don't have to wait in crowded waiting rooms. So the downside to this, though, is that the patients get access to round the clock to their physician. So that's not necessarily a draw for the physicians. And one thing to know with concierge medicine is that they will bill insurance for services that are not covered, as opposed to direct primary care where they will not. All right, so let's start talking about the metrics and how you're going to monitor your operations and your success. So in your first days, you're going to be troubleshooting and addressing the things you didn't realize you'd have to spend your time on. Flukes in your EMR workflow, staff not checking portal messages, things like that. In your first weeks, you're going to still have a focus on marketing and patient retention, which is what many of the metrics on this slide are focused on. Excuse me. I like monitoring patient acquisition cost because it goes down the longer that you measure it. Hypothetically, that's the plan. You'll need to track the expenses for your marketing efforts and then track the number of new patients generated from it. You want this number to be as low as possible, but it's not uncommon for this number to be in the hundreds initially. This is something I feel that you need to be concerned with about, because each patient could potentially generate thousands in revenue for you. So it's expected that, especially in your initial days, weeks, months, and even years, it's going to cost you more to attract those new patients. So in order to be able to track this accurately, you're going to be asking patients how they heard about you, and your staff will need to be trained on the tracking methodology for this. So to determine the revenue per patient, you're going to calculate the revenue generated throughout the patient's treatment history over a defined period of time. So the longer you're open, the longer the time period will be, though you'll want all patients measured over the same time period. And you can tell that staff training and engagement is key here to ensure that you're getting accurate information, because your staff are going to be the ones who are collecting this information for you, and they'll need to understand why it's important. As you'll be focusing on patient retention, you're going to want to ensure the satisfaction of the patient. So this starts with appointing, but wait time is typically a heavily weighted factor when a patient is deciding if they like a practice or not. So those are two things you got to watch. How long does the patient have to wait to make an appointment? And then how long are they sitting in your waiting room? Measuring appointment length can likely be automated with your EMR utilizing like an audit log or timestamps. You're going to look at the time at which the patient checked in to when they see the provider. And aside from increasing satisfaction and thus retention, it gives you an indication as to whether or not your staffing is appropriate and helps you to identify areas where adjustments may be needed. You may also notice trends on certain days that you can dig into to adjust staffing, scheduling, things like that. And just one more reminder that long wait times are one of the main reasons that patients leave practices. Chart completion time is important for compliance within your practice. You should have a policy in place that sets the expectation for how long a provider has to complete the chart. With my background in compliance, my preference is same day. However, I'm realistic that this isn't always possible. So it should never be more than 3 days, because this allows for time for labs, path, everything that they need to come back for the assessment. And for patient satisfaction, given that it's the year 2023, most practices are utilizing automated patient satisfaction surveys. I personally get a text and/or email from my doctor's offices after each visit to complete a survey, more like 7. But a lot of them even ask for Google reviews to help drive more patients to their practices. Again, this goes back to marketing and attracting new patients and retaining them. So I highly recommend that you invest in some sort of software that automates this process and tracks and analyzes your results for you. Another benefit to using software is that these companies have mastered the art of collecting and leveraging this data for you. It'll focus on key influences, such as the promoters and detractors of your practice. Everybody knows that a happy patient is going to tell approximately 1 or 2 people, and a dissatisfied patient is going to tell at least 10 people. So you want to make sure that you are doing some service recovery when you need to, and that you're keeping an eye on both the attractors and the detractors. So once you're 2 weeks in, you can expect to start receiving your first insurance payments. Not all of your insurance payments, but some do come in that quickly, so long as the claims were submitted on the first day. So this is the list of metrics to be tracked but the actual number is nearly infinite. And these are just the ones that I recommend that you start with, and it's going to evolve as your practice grows. So you're going to start measuring profitability once you start receiving payments. These first two could also be on the previous slide, but they gain importance as time goes on and as your patient panel increases and payments are made regularly. Daily charges will include all charges submitted on a date of service, but this doesn't necessarily align with your anticipated payment. Your charge is typically higher than what your actual reimbursement is going to be. This is also an indication as to what services are most profitable for your providers and practices. Occasionally, you're unfortunately going to need to make a decision to stop performing certain procedures because they're not profitable for the practice. So for example, in primary care, you may have a provider who does a nasolaryngoscopy, and if there aren't enough performed to justify the cost of the supplies and the staff, you're going to need to make the decision to refer to ENT instead of performing that internally. Daily collections includes point of service collections from patients and payments from insurers, and it gives you an idea of future cash flow. You can also break this down by provider or service type based on your specialty. And we all know that some payers pay faster than others, which is why it's important to track insurance processing time by payer. And aside from managing cash flow, this is also key information to monitor when negotiating with payers. Oftentimes, practices may need to focus on who pays faster to improve cash flow, and tracking this will allow you to have actionable data readily available. The next several service metrics will provide insight into your billing processes, which is going to give you insight into the management of this function and whether you outsource or keep your billing in-house. Typically, what we see is that the new practice, when they're smaller, they keep the billing in-house, and as they grow, they decide to outsource it. So these are important whether you're doing it in-house or outsourced, but your clean claim rate is a crucial measurement of the effectiveness of your documentation, coding, charge entry, and billing processes. Clean claims are not only a reflection of compliance, but they also speed up your payments, and the cost of reworking claims is astronomical, even if it's a rejection, not a denial. This is also the opportune time to evaluate your billing processes and see where improvements can be made to improve accuracy. So naturally, the next metric to evaluate is your denial rate. This represents the percentage of claims denied by payers during a given period. There's a reason that I say dedicating time to reducing denials is revenue generating work. The cost to rework a denial is higher than working rejections, which are like those front end to the claim didn't even make it to the payer denials. It can be upwards of $30 per claim to rework those. So when I think of the importance of this metric is self-explanatory, there's also a lot of risk to be mitigated with managing denials. Just because a claim was paid doesn't mean that it was correct. So this is one more ring of defense to protect the money that's owed to you. So we're pretty deep into revenue cycle management at this point. Days in AR is the average number of days it takes a practice to collect payments. You want this number to be as low as possible, and it gives you an indication of both your staff's performance as well as payer performance. And looking at total revenue will start as soon as you start receiving payments, but this drove a lot of what you did in your information gathering, pro forma, financing phase. So you'll want to monitor this compared with your projections. And monitoring new and established patients is important, especially in your first months and years as you are gathering firm data on patient attraction and retention. The longer you're open, the more your metrics are going to evolve, and you'll start looking at revenue cycle costs to collect, write-offs as a net percentage of patient revenues, things like that. Gathering accurate data, analyzing it, and acting on it is one of the most important things to do in a practice. So now that you're open, you've been open for several years, the longer you're working in your systems day in and day out, the more improvements you're making. A lot of things that made sense in theory may not make sense in practice. Your initial processes will be established based on best practice and what other practices are doing, but what works for you or what worked for others won't necessarily work for you. Never underestimate your culture at your practice. A lot of these positions, such as your front desk staff and MAs, they work for a small amount of money and they will leave you for 25 cents more per hour down the street. And the hard thing about this is that these are also the positions that determine much of your success. They're the first people that your patients interact with at the point of scheduling and check-in. And a lot of times they determine if the patient's going to stick with you or not. Someone should be designated to monitor all reviews online, including social media. And it's assured, like I mentioned before, you're going to need to engage in some sort of service recovery. Not all practices want to continue growth at an astronomical rate, so you're going to want to determine at what point you consider your patient panel full. Also, continually assess additional expansion opportunities, whether it's new locations or additional providers. As time goes on, you'll learn more about reporting, not just for regular monitoring, but also ad hoc reports. You might need to take a look at productivity, audit logs, certain billings to troubleshoot and make corrections. And insurance companies, they're not invested in paying as much money as they can. They're invested in making sure that they keep as much money as they can. And insurance companies are not only looking for overpayments, but underpayments as well. And I can't stress this enough to our clients that overpayments seem like the obvious low-hanging fruit to take a look at, but underpayments, meaning if your providers have the mindset of they're always going to bill a level 3 because they'll stay under the radar, unfortunately, that's not entirely accurate, because or I shouldn't say it is, but it can be viewed as enticement, which is a stark violation, which the government also loves to audit and fine. Y'all, I talk fast and I don't know how. I'm still going to the very last minute, but always perform risk assessments, test your staff, and take advantage of networking opportunities as well. There's so much more to say, but I did want to leave time for questions and answers. There is a slide of resources here. There's a lot of stuff that I didn't have a chance to cover, and I'm sure that there are a lot of questions. By all means, shoot me an email or give me a call afterward to talk about anything else that you'd like to review. I need to advance the slides for you to know what I'm talking about. And lastly, here is just a list of revenue cycle services that we offer in addition to new practice startups. So thank you so much for your time this morning. I am very, very appreciative. I'm happy to take any questions that there are now. And as promised, here is my contact information. So with that, Claudine, are there any questions?
There are no questions currently in the chat. So I think it'll be good for us to conclude today's webinar. If everyone can please be sure to take a few minutes to complete the survey that I did post in the chat today. And just a reminder that a copy of today's slide deck, as well as a copy of the recording, will be sent out to you in the next few days. As Julie's mentioned, if you have any questions, please feel free to reach out to her. And we hope that everyone enjoys the rest of their day.
Thanks so much.
Thank you.